Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for the European Hematology Association, EHA. Welcome to this podcast on the innovative tools for monitoring monoclonal gammopathies. We have the pleasure to have here with us today Professor Bruno Paiva, who is an expert in multidimensional analysis of hematological malignancies. His research aims to improve differential diagnosis, risk stratification, and monitoring of patients with monoclonal gammopathies, such as multiple myeloma. Welcome, Dr. Paiva. Can you please introduce yourself?
Thank you very much for having me here. I'm Bruno Paiva, Director of Flow Cytometry and Myeloma Research at the University of Navarra in Pamplona, Spain.
We're here to discuss the innovative tools that are being developed to monitor monoclonal gammopathies, from MGUS, monoclonal gammopathy of unknown significance, to multiple myeloma. Let's start with the monitoring of MRD in multiple myeloma. Can you please explain how is MRD monitored at the moment?
Okay, nowadays it's very important to understand how to monitor patients because we are now living in an era where treatment has improved remarkably, is very effective, and this needs to be measured, but also because patients are living longer and longer and are also enjoying longer remission-free periods, meaning that patients will be monitored multiple times. So it has become tremendously important, not only because of it, but also because given the fact that there are more and more treatment options, we may be soon reaching a scenario where precision medicine, treatment individualization will become a reality for the patients with myeloma. And I honestly believe that perhaps in addition to genetic risk diagnosis or upfront, depth of response, particularly MRD assessment, will be paramount for treatment individualization. Nowadays, we are measuring MRD according to the guidelines of the International Myeloma Working Group that were published in 2016, which, by the way, will probably be updated next year. But the guidelines currently refer to the use of next generation flow cytometry using the Euroflow protocol, as well as next generation sequencing using adaptive to measure MRD in the marrow in those patients achieving complete remission. And then there is the imaging MRD negative criterion that requires CR plus negativity by either NGF or NGS and a negative PET-CT. I think it's important to recognize that whereas in newly diagnosed patients, perhaps the utility of PET-CT in the context of a negative MRD result by NGF or NGS with high sensitivity 10 to the minus 6 may not be that relevant. By contrast, in the context of relapsed refractory patients, those, for example, treated with CAR T cells or T cell engagers, PET-CT is very, very informative. Now, what to expect from potentially new guidelines next year or the year after? I think that the new guidelines will probably see the incorporation of mass spectrometry as a very high sensitive method to measure the M component in the serum. Multiple groups have shown it is more sensitive than immunofixation, and whereas the CR criterion is losing prognostic value in some disease settings, mass spectrometry is showing to be very, very prognostic and complementary to MRD assessment in the marrow. So on the one hand, mass spectrometry, on the other hand, the utility or how to apply the next generation methods that we are using in the marrow, but in peripheral blood. This is very important because, as I said at the beginning, patients are living longer and longer, remission-free intervals, they are being monitored multiple times. We nowadays know that MRD kinetics are much more important and relevant than a single assessment, and multiple assessments may be feasible in clinical trials but are impractical in routine practice and, more importantly, are inconvenient to the patient. Therefore, it will be very important to establish what are the time points and the type of information we can obtain from the use of NGF or NGS in the peripheral blood, what we are now calling PRD or peripheral residual disease. My opinion is that, based on data that, for example, our group has been reporting in recent meetings and publications, is that whereas during initial stages of treatment that are more intense, MRD must continue to be assessed in the marrow, eventually at later stages of treatment that is less intense, for example, maintenance or observation if patients are not being treated until disease progression, there eventually bone marrow aspirates can be reduced, sparse throughout a few years, and in between we can rely on the peripheral blood and serum for a more dynamic and minimally invasive assessment of treatment efficacy.
Minimally invasive assessments are especially important in patients with earlier stages of the disease, like smoldering myeloma or even MGUS. Are you able to detect the early stages of the disease in the peripheral blood of these patients?
We are. I'm glad you asked that question because I'm proud to say we have ongoing probably two of the largest studies, translational studies, conducted in patients with MGUS and smoldering myeloma. These are called No More MGUS and the Immunocell study, No More MGUS in MGUS, obviously, and the Immunocell study in patients with smoldering myeloma. What are our key objectives? Well, these studies rely mainly in the peripheral blood. We want to replace the bone marrow. Actually, let me rephrase it. We don't want to replace the bone marrow. I think that the bone marrow will remain a standard specimen to evaluate, for example, in a patient with newly diagnosed smoldering myeloma. What we do want is to offer the peripheral blood as an alternative to the marrow for sequential dynamic monitoring during patient evolution, because the free light chains are measured routinely in the serum, the M component, hemoglobin, creatinine, but we cannot monitor plasma cell burden in the marrow every 6 or every 12 months. That is not feasible from the patient point of view. So we want to offer the blood as an alternative to measure not only circulating tumor cells, tumor burden in the blood, but also to perform immune profiling, as patients may overt to active disease not because of high-risk tumor features, but because of immune escape. Or by contrast, have high-risk features of progression, but remain stable because of immune surveillance. And we are focusing on blood because we do believe that with longitudinal monitoring throughout a couple of years, eventually 3 to 5 years in smoldering myeloma, 5 to 10 years in MGUS, we may find the tools, the biomarkers, and the models that will allow us to identify patients with a benign condition. We believe that the expansion of oligoclonal and even clonal B cells and plasma cells may be a physiological process reflective of aging, and therefore the detection of an M component in the serum maybe should not be considered as a precursor condition to a tumor or a pre-malignant condition. Definitely, what we want to offer are the tools so that patients could be diagnosed with a monoclonal gammopathy, either of clinical significance, because there is risk of transformation to myeloma or light chain amyloidosis or lymphoma, such as Waldenstrom's macroglobulinemia. Also monoclonal gammopathies of clinical significance, for example, those affecting the kidney, renal significance. And on the other hand, most of the monoclonal gammopathies have no clinical significance. In my view, this is paramount not only to facilitate early intervention once we identify all the patients that should not be overtreated because they have a benign condition, but also from the patient point of view to reduce anxiety and visits to the hospital and laboratory testing. We should not forget that MGUS is as prevalent as probably 4 to 5% of individuals aged over 40, 50 years. And I think it is inconceivable to diagnose hundreds of thousands of people in Europe with a condition of undetermined significance that they will carry for the rest of their lives. I do believe that it is our obligation, and we do have the tools to finally make the differential diagnosis and identify those gammopathies of no clinical significance.
So, how far are you from being able to determine the risk of progression in patients that have MGUS? Are the tools for more precise risk stratification and prediction of disease progression close to clinical practice, or are they still being developed?
Well, it's a work in progress for multiple reasons. I do believe that we will find the tools. One important aspect is that it will be multifactorial. So it's not one tool, rather we will have to integrate clinical parameters with tumor genomics and tumor and immune monitoring in the peripheral blood. It's work in progress because the rate of disease progression is very small, for example 1% per year in MGUS, 10% per year in smoldering myeloma. The progression of MGUS into malignancy is not linear, maybe myeloma, light chain amyloidosis, lymphoma, as I said before. For example, to predict the risk of transformation in light chain amyloidosis, we'll probably have to integrate with other pieces of information, such as the glycosylation of the M component. To predict the risk of transformation into Waldenström's, we'll probably have to integrate tumor burden with mutations in MEDIAT or CXCR4. The risk of transformation will probably be different in IgG, IgA, in individuals with different age, decades. So we need large cohorts, and we do know that a single assessment, a single snapshot is not enough. We need the dynamic component of monitoring. So to answer the question in MGUS, our project No More MGUS aims to enroll 5,000 individuals with MGUS in Spain that will be monitored every year during 5 years, meaning probably a 10-year duration of project, only for enrollment and sequential samples, and up to 25,000 samples. It's probably one of the largest projects conducted in Europe. We have currently enrolled more than 1,500 patients, and some of them we are already monitoring in the 3rd year. So we will get there, but it will take some time. We are more advanced in smoldering myeloma. We had the opportunity to publish data from an interim analysis in 2022 showing how the assessment of circulating tumor cells not only can replace the assessment of tumor burden in the marrow, but also that is probably more informative.
Let's go back, please, to patients with active multiple myeloma and how MRD is assessed. Do you think the introduction of innovative tools will change the definition of MRD positivity, and this will influence treatment decisions?
Ideally, that is also work in progress. So now we shift again into patients with active myeloma on treatment, after which or during which we are monitoring MRD. It should be noted that MRD is probably one of the most, if not the most relevant prognostic factor, meaning that the expectations on MRD is to use it not only as a prognostic factor, but also as a biomarker to individualize treatment approaches. And there are two options in which MRD can be of some utility. One is to intensify treatment if patients continue to show MRD with the upfront pre-planned treatment before disease progression. In other words, to try to eradicate the MRD clone with a different line of treatment, with drugs having different modes of action, in order to eradicate MRD and prolong patients' progression-free and overall survival on the one side. On the other side, for patients achieving deep 10 to the minus 6 sustained MRD negativity, particularly those with standard risk myeloma at diagnosis based on genetic alterations, the possibility of stopping treatment. Never immediately after treatment initiation, but probably 2 or 3 years after treatment initiation. Do I mean stopping treatment because the patients are cured? No. Hopefully some may be cured, but we know that most are not. So the idea is not to stop treatment because patients are cured, but to stop treatment in order to offer a treatment-free interval that may well last for 5, 7, 10, 12 years, so that patients can improve their quality of life, be away from the hospital and of drugs for many years, and in the case some relapse and some will relapse, the moment they relapse and will be offered a second line of treatment, patients will not be refractory to the last line. They will not be refractory to the drugs they were being exposed to. It's almost like treating de novo that myeloma that is progressing again. And we all know that in such a scenario, a second line therapy can produce again very long outcomes, meaning that this way we could improve patients' progression-free and overall survival. Not only that, but also in the meanwhile to improve quality of life with long treatment-free periods.
So during these long disease-free periods, will you be monitoring if the disease comes back in peripheral blood?
We must, and we must continue monitoring, and it must be blood, because you cannot be repeating bone marrow aspirates every couple of months or every couple of years throughout a decade.
Well, thank you, Dr. Paiva, for giving us your time and expertise, and thank you to all of you for listening.